syncope, fatigue. Okay, so some of the common symptoms we have are chest pain, dyspnea, cough, palpitation, syncope, fatigue, and peripheral edema. And it's important to be able to take a clear history so that you can pinpoint where these things are coming from. So we'll start by discussing chest pain, okay? So chest pain is one of the common symptoms that patients with heart disease can come with, and it's in fact one of the commonest reasons why people seek cardiologist review, whether it is of cardiac origin or not. But a lot of times when people have chest pains, one of their fears is that they are having a heart attack. And some of the common cardiac causes of chest pain include ischemic heart disease, coronary artery spasm, pericarditis, mitral valve prolapse, aortic aneurysm, and aortic dissection. The other non-cardiac causes of chest pain, which are listed there. So we're going to be looking at the chest pains that are of cardiac origin. What are their characteristics? And the pain of angina pectoris and myocardial infarction is usually due to myocardial hypoxia. And some of the types of pain patients could complain about will be retrosternal, heavy or gripping sensation with radiation to the left arm or neck. And it's usually worsened by exertion and relieved by resting. When the patient rests for about 3 to 5 minutes, the pain resolves, or when they take nitrates. So usually chest pain that is suggestive of angina is usually retrosternal. We say this heavy or gripping in nature, and it radiates to the left arm or neck, and is usually provoked by exertion and eased with rest or taking nitrates. Similar pain, if you have that type of pain at rest, pain that is gripping or heavy and is occurring at rest, one would think of an acute coronary syndrome. And also, if there's a severe tearing chest pain that radiates to the back, that could be indicative of aortic dissection. So the character of aortic dissection pain is tearing. And for pericarditis, the pain will be sharp and also central, and is worsened with movement of respiration, and also relieved by leaning forward. When the patient lies down, the pain tends to worsen. When he leans forward, the pain tends to improve. And there are other chest pains like that are shared with Da Costa syndrome, which is a stabbing left submammary pain, which is usually associated with anxiety. Okay, so another symptom that is common with the cardiovascular system is dyspnea. Dyspnea is also known as difficulty in breathing. So patients with heart failure tend to have difficulty in breathing, and this is usually as a result of pulmonary edema. This makes the lungs stiff and increase the respiratory effort required to ventilate them. Now, a lot of times the dyspnea would be initially on maybe moderate to severe exertion, and it usually progresses. So once you have a progressive dyspnea, you could think of heart failure. And also, you make them to breathe fast. So they could also have tachypnea. Notice the patient breathing fast. And this is usually due to stimulation of the pulmonary stretch receptor. So they usually have increased respiratory rate. They could also have autopnea, which is like a worsening state of this. Then when the patient lies down, when they lie flat, blood is redistributed from the legs to the chest, which leading to an increase in central and pulmonary blood flow. This would usually worsen pulmonary edema because the blood flows from the venous system into the right side of the heart, from the right side of the heart to the lungs. So when patients lie down, there's increased venous return to the heart. And this increased venous return to the right side of the heart, that means more blood will be pumped to the lungs. And because the left side of the heart is not effectively pumping out the blood that is coming from the lungs, there is a backlog of blood in the lungs. So this would usually make the patient breathless, as there will be like a flooding of the lungs at that point in time. So that's what causes autopnea. And also, there is the patient may have paroxysmal nocturnal dyspnea. This is when a patient wakes from sleep fighting for breath. How they usually classically describe it in those days is that the patient wakes up from sleep, runs to the window to receive some air. Okay, so the thing there is that patient wakes up very breathless, and this is caused by the same mechanism with autopnea, but the difference there is that the fluid accumulation tends to be more because the sensory awareness is reduced during sleep. So more fluid usually would have accumulated in lungs before the patient wakes up. So we are on slide 7 now. On slide 7. So also, they could come with hyperventilation with alternating episodes of apnea. This occurs in severe heart failure, what we call Stokes respiration, where the patient has alternating periods of apnea and then hyperventilation. So this occurs in severe heart failure. So you'll notice that at the point the breathing will cease, and then it starts building up momentum gradually, and then it ceases again. So that's Stokes breathing. And then sometimes they may have periods of hypopnea, which rather than complete apnea. This is termed periodic breathing, but the two variations are known together as central sleep apnea syndrome. Okay, another symptom of cardiovascular disease patients will have is palpitations. And this just means that there's an increased awareness of the normal heartbeats or the sensation of slow, rapid, or irregular heart rhythms. The most common arrhythmias felt as palpitations are the premature ectopic beats and paroxysmal tachycardias. One way when you are taking history from this patient to get more details is to ask the patient to tap out the beats of the heart rate. Okay, so usually patients will have palpitations when they have arrhythmias, usually premature complexes and paroxysmal tachycardias. And usually other history should be sought as to the etiology of the palpitations, whether they are on taking caffeine containing drinks, alcohol, or other things that can predispose to palpitations or arrhythmias. So syncope is another important symptom of cardiovascular disease. And this refers to a transient loss of consciousness, and is usually due to inadequate cerebral blood flow. There are various types of syncope that come from the heart. It could be vascular, obstructive, or from arrhythmias. The vascular causes could be neurocardiogenic, like vasovagal syncope, which because of excessive vagal stimulation, there will be peripheral vasodilatation, which will cause venous pooling. And then this would affect the blood supply to the left side of the heart. So less blood is pumped out of the left ventricle. And because the blood coming into the left ventricle is small, because of reduced venous return or reduced preload, the blood coming to the left ventricle is so small, and this makes the left ventricle to contract vigorously, which will also trigger other mechanoreceptors and cause further worsening of vasodilatation and affect cerebral perfusion, leading to syncope. Patients could also have a postural hypotension. This is basically patients that have autonomic neuropathy like diabetes, patients that have patients that are on diuretics, antihypertensive medications, especially diuretics, or patients that have lost blood acutely. Usually, how would you know if somebody has pressure? By taking the blood pressure in two positions, lying and standing. And usually the blood pressure will, we're on slide 10 now. The blood pressure will fall by 20 meters of mercury. Systolic blood pressure will fall by 20 meters of mercury in the standing position, and then it will fall by 10 meters of mercury. Usually you ask the patient to lie down, you take the blood pressure, then wait for about 3 minutes before you ask them to stand, then wait for about 3 minutes before you retake the blood pressure. This will make the, so and if you notice this difference of 20 systolic and 10 diastolic, then definitely the patient has postural hypotension. So the other causes are the micturition syncope, which is actually when patients are micturating because of increased vagal stimulation. They could just have they could have peripheral vasodilatation, and this could lead to syncope. Carotid sinus syncope. There's probably people that wear tight neck collars. Carotid sinus could be stimulated, and this could lead to syncope. So other causes of syncope are listed there, so like aortic stenosis, hypertrophic cardiomyopathy, tetralogy of Fallot. All this is because they reduce the outflow of blood to the peripheral circulation and thereby cerebral perfusion. That's basically what happens. And when the patient falls, usually it's like a compensatory mechanism. The blood will flow back to the brain. Also, patients with heart disease can also present with fatigue. They may come with feeling generalized body weakness, and this may be as a result of heart failure. Other contributing factors may include poor sleep, side effects of medications, particularly beta blockers. It could also come as a result of electrolyte imbalances from diuretic. Some of the diuretics we give can cause loss of potassium, and this can lead to a good degree of body weakness. It's also known to lead to even paraparesis in some patients. So we need to look for some of these things when patients come with fatigue. And also some of it could be as a result of systemic infections like endocarditis. So patients could also have peripheral edema. Peripheral edema, we are on slide 12, sir. Slide 12. Where like in heart failure patients, where there is activation of the renin-angiotensin-aldosterone system because of the hypoperfusion of the kidneys, the renin-angiotensin-aldosterone system is triggered. This leads to salt and water retention. This would increase hydrostatic pressure, and with increased hydrostatic pressure at the capillary level, you could have blood seeping into the interstitial. This is what causes pedal edema in these patients. So heart failure patients will have pedal edema. Okay. Okay, so some other symptoms that are important to mention that we didn't, that were not captured in the slides are things like intermittent claudication. For patients that have cardiac disease could have intermittent claudication. This refers to pain in the calf area, especially when the patients walk a distance. This is usually caused by peripheral vascular disease when there's like plaques or atherosclerotic lesions in the vessels supplying the lower limbs. So when the patient walk, the muscles compress the vessel, so there will be reduced blood supply to the muscles. So this will cause pain in the calf muscles. Okay, so when the patient rests for a bit, then the pain would resolve. So that's another symptom of heart disease. And then we mentioned cough initially. We said so cough is a very important symptom of cardiovascular disease. Although of course you can have it in other systems, but the cough from cardiovascular disease is usually worsened when the patient lies down, and it's productive of frothy sputum. Frothy means the sputum is foamy. The sputum contains foam. So usually frothy, and this is because of the it comes with some form of elements from the lungs, some air bubbles. So the sputum is usually frothy, and occasionally the patients could have blood-stained sputum, which is hemoptysis. You could have hemoptysis. There's some blood, and sometimes this froth is pinkish, looks pinkish. So because of because there may be some rupture of the capillaries because of the increased pressure there in patients with heart failure. So they could have cough also. And cough is usually worse on lying down. So one way you can actually differentiate, is this cough coming from the heart or is it coming from the lungs? Is by asking, does it get worse when the patient lies down, or is the cough worse at night? So nocturnal cough, okay, is what is more characteristic of cardiac disease or heart failure. All right, so some of the examination findings you can see, important examination findings you can see in patients, in cardiac patients. When you do a general examination, on slide 13 now, you could see pallor, jaundice, cyanosis, clubbing, splinter hemorrhages, pedal. So pallor, we know what pallor occurs when the patients are pale, and sometimes this could be a precipitant of heart failure or even a cause of heart failure in itself. A lot of heart failure patients have hepatic congestion, and it could lead to cardiac cirrhosis in some patients. So this could lead to jaundice. Cyanosis could be central or peripheral. Cyanosis means bluish discoloration of the mucosa. Usually occurs when the oxygen saturation drops below 85%. Means you have a lot of deoxygenated hemoglobin in the system, and the oxygenated hemoglobin is more blue. So in the mucosa, you see bluish discoloration. And for central cyanosis, you could see it around the mouth and the buccal mucosa. And then for peripheral cyanosis, it's seen in the lower limbs. Usually in some conditions, maybe when there is peripheral vasoconstriction, you could have just peripheral cyanosis rather than central cyanosis. So cyanosis could be peripheral or central. And also, the patient could have finger clubbing. Finger clubbing could occur in patients that have a congenital heart disease, cyanotic congenital heart disease like tetralogy of Fallot, or in patients that have infective enteritis. Also, you could see things like splinter hemorrhages, which are small small hemorrhagic nodules under the fingers, and then this occurs in infective endocarditis. And then you could also have things like pedal edema. I think we have explained what causes pedal edema. Dependent pedal edema, you have to examine the lower limbs for pedal edema. So these are some things you can see on general examination. On usually cardiovascular system examination, when you are examining cardiovascular system, you start with the pulse. And the things you really want to note about the pulse is the rate, the rhythm, the character, and the synchronicity. So the rate, usually we know that the normal heart rate is between 60 to 100 beats per minute. So you want to make sure that there is no tachycardia. If there's tachycardia, you want to know what is causing the heart rate to increase. Is the patient, is he anemia? Is it fever? Is it thyrotoxicosis? Is it anxiety? So you have both physiological causes and the pathological causes of tachycardia. From exercise, anxiety, those could be physiological causes. Or pathological causes are things like anemia, sepsis, fever, heart failure, pulmonary embolism, thyrotoxicosis. So the pulse is very important when you're evaluating a patient. The rate is very important. And you could have bradycardia. So you want to know what is causing the bradycardia. Does the patient have any heart block? Does they heart block? Or also physiologically, patients that are trained athletes tend to have pulse rates that are less than 60. And also during sleep, the heart rate tends to drop. So the pulse rate could be a little bit less than between 50 and 60 when people are sleeping. But apart from that, you need to rule out other causes of low pulse, like pathological causes will be like raised intracranial pressure, sick sinus syndrome, heart block, hypothyroidism, hyperthermia. So you need to check for pathological causes. And also you want to know the rhythm. Is the pulse, is it regular or irregular? Is the pulse regular or irregular? This would the irregularity of the pulse would help you to know whether you are having certain arrhythmias, like atrial fibrillation that would usually present with irregular pulse. Then if you could be regularly irregular in some cases of premature ventricular complexes that just interrupt the rhythm occasionally. So the rhythm is very important. Also, you want to know the character of the pulse. Generally, you want to know whether it's a small volume pulse, which would occur in conditions like heart failure, pericardial tamponade, in hypovolemic patients are in shock. Okay, so, and then you could have a large volume or a bounding pulse, which would occur in patients that have basically hyperdynamic state. Things like fever, anemia, wet beriberi, aortovenous fistula, or sepsis, sepsis. Also, you want to check for radiofemoral delay, which could occur in patients that have coarctation of the aorta. And also, you want to check for radioradial delay. So you want to check for synchronicity. So all these are important in tying up your diagnosis in patients that have heart failure. After taking a pulse, you want to do the blood pressure. So blood pressure actually should be taken on both arms, and the higher value should be taken not just on the right arm, okay, should be taken on both arms. I think this source put right arm because we are usually expected to examine the patient from the right. So the ideal thing is to take on both arms, and then that's if you're in the clinic. And then after that, you can use the arm with the higher value. And the patient should be seated comfortably, relaxed. The back should be relaxed, and the patient should be well rested. So the sphic should be wrapped around the upper arm, and the inflation bag should be over the brachial artery. So I think the important thing here is to note the sounds that when you, after you inflate the cuff and you put your stethoscope over the brachial artery, the first sound here is the first coronal cuff sound, which is the systolic blood pressure. And as it falls, the next, what you're going to hear the second coronal cuff, third coronal cuff, and then the fourth coronal cuff, where the sound becomes muffled. But when the sound disappears, the fifth coronal cuff sound is important. That is where you mark as the diastolic blood pressure. Okay, so it's important to have a clear idea of these coronal cuff phases. I think there are possible MCQ questions, the coronal cuff sounds. So the first sound is the point at which you first hear the sound when you're deflating your cuff, and that's what marks the systolic blood pressure. And the diastolic blood pressure is the fifth coronal cuff sound, where the sound disappears. In some instances, you will not be able to get the fifth coronal cuff sound. Like sometimes in pregnant women, you may keep hearing it. It gets to the fourth, it's muffled all the way to the end. So you may need to use when you start getting the fourth as the systolic blood pressure, as your diastolic blood pressure. It also can occur in patients that have aortic regurgitation. Okay, so we know normal blood pressure should be less than 140/90, and anything less than 90/60 is hypotension. So any blood pressure more than 140/90 is hypertension. Blood pressure that is less than 90/60 is hypotension. So the jugular venous pressure is also important to check in patients that have cardiovascular disease, because if it's elevated, it may be a pointer to heart failure. And usually what they use to measure this JVP is the internal jugular vein, because the internal jugular vein has no valves, and it's not obstructed by any tendons or sheets, unlike the external jugular vein, which has valves and is flow can be observed by fascia in the neck. So usually what we use to check for jugular venous pressure is the internal jugular vein, and the normal JVP is usually less than 3 centimeters of water, which is equivalent to the right atrial pressure of 8 centimeters of water when measured with reference to a point midway between the anterior and posterior surface of the chest. So the venous pulsations are not usually palpable. So usually it's important to distinguish the JVP from your carotid artery, because they are all around the same region in the neck. So how do you do that? The JVP is not pulsatile. You cannot palpate the pulsation, and it has a double wave. The JVP is it runs between the two heads of the sternocleidomastoid and runs on the medial border of the butt of the muzzle to the angle of the jaw. So that's that's the anatomical location. And also when you apply pressure to the abdomen, you could see that there will be an increased pulsation in the JVP. And then when the patient breathes in, the JVP would usually fall. Then also when the patient sits up, the JVP will fall. So those are some of the things that help us reach JVP from the carotid artery. So basically, it can be elevated in certain conditions like heart failure. And then there's what they call the Kussmaul sign, where it increases paradoxically in inspiration. And this can be seen in pericarditis or cardiac tamponade. Another thing that could increase it is overtransfusion or excessive infusion of fluids. And then also in congestive cardiac failure. And then it can also be increased in superior vena cava obstruction. And it could be reduced in patients that have hypovolemia. So it's a very important index to monitor for a patient that is in shock or you're not sure of the fluid status. The JVP could be a very strong indicator of the hydration status of the patient. So it's generally, the normal JVP has 3 waves and 2 troughs. Okay, so the AC and V wave and the X and Y trough. The A wave basically coincides with the right atrial pressure when the atrium contracts to pump blood into the ventricle. And then the X descent is the period of ventricular fin. Then you see the C notch there. That corresponds with closure of the ventricular valve. And then the V is when there's filling of the right atrium of the right atrium. Then the Y descent corresponds with the period where the AV valves open up to empty the contents of the atrium into the ventricle. So next we go to the precordium. After looking at the precordium is patients should be examined in 45 degrees. The cardiac apex should be is usually located in the 5th intercostal space mid-clavicular line. Usually you want to inspect the precordium to see whether it's active or not active. If it is displaced, then you know that there may be something going on in the heart. So usually displaced apex downwards and laterally would usually point to maybe hypertensive heart disease, especially if it is heaving and pushing your hands. But if you have an apex that is diffused, that will point more to a dilated cardiomyopathy. If you have a tapping apex, that will point to aortic stenosis. If you have an apex so it's like I had some network issues. Okay, so you check the precordium, So, hello, are we together?
Yes. Sir.
Hello.
Yes.
Yeah, can you hear me?
Yes.
Okay. So for auscultation, usually the bell of the stethoscope is used for low pitch sounds, and then the diaphragm is used for high pitch sounds. So I think because of our time, maybe we'll just quickly wrap up this session next time and move on to another topic because of the time.
Yes, sir.
I know we have another lecture by 5.
Yes.
Okay, so we'll wrap up this next time, and then before we move to another topic. Sorry for the delay in starting. That's small technical issues. Yeah, are there any questions?
No, sir.
Okay, fine.
Thank you, sir.